Good evening and welcome everybody. Dr. Khanna, the session old boys can also fail. It is actually very true. Sometimes some situations can arise where even the best interventionist or the most experienced person can fail in certain situations, or there may be no answer to what was the final result of procedure. So this is one such example. So this is a 67-year lady, hypertensive, and she had a recent history of pneumonia, and she was treated at a outside hospital in Lucknow, and then she came to Delhi for getting her aortic stenosis treated, and she was said that she would be needing aortic valve replacement, and because of bad lungs and bad kidneys and a recent history of heart failure with chest infection, she was a high risk case, and her predicted risk of mortality STS score was 8%. And uh, she consulted us, and we planned for a TAVR because she was standing as a high surgery after the surgical consultation was also done. So, uh, this is the echo picture. You can see she had a normal functioning left ventricle, but there was, for some reason, there was a moderate TR with RV dysfunction that was reported on the echo, which was done outside, and it was confirmed in our hospital also. So she had a normal left ventricle, but a dysfunctional right ventricle. And the aortic stenosis was severe. The valve area was 0.26 centimeters square, and the indexed valve area was 0.125 centimeters square per meter square, and the mean pressure gradient was 66. So she was planned for TAVR, and this was the CT analysis done, and which showed that the annulus area was 434.7, and there was some calcium which continued to the LVOT also, and the LVOT was 441.7 millimeters square. The minor axis and the major axis of the aortic annulus was 20 and 24, and the LVOT was also 24 into 18. The sinotubular junctions was 32 into 38 into 35, which was fairly large, and the sinus of Valsalva was 25, 35, and 30. The coronary ostia height on the left side, which means the left main, was 9.9 millimeters, which is low coronary ostia height, less than 12, and the right coronary ostia height was 15. So there was even though the sinus of Valsalva was wide, but because the coronary height was low and the patient had a Sievers type 0 aortic valve, decided to do coronary protection in this patient because bicuspid valves can sometimes have bulky leaflets, which can even occlude the ostia of coronary arteries if they are large and bulky, and even if they're in the intermediate range. So, depending upon the area, 434, there was a possibility of taking 23 and 26 valve. And because the sinus was large, and we decided to go on the higher side of upsizing, and we chose 26 millimeters, but we did it minus 2 cc the volume of balloon for 26 millimeter, which would get the valve size somewhere between 23 to 24 and 23 to 26, and the percentage of oversizing was calculated as around 10 to 10.2%. The minor axis was 20 millimeters, and the major axis was 24. So ideally, the pre-dilatation balloon should be around 18 or 20. We chose 22 millimeters for dilating the bicuspid aortic valve, and if required, the post-dilatation, we would do it with a 24. So this was our planning, a type 0 bicuspid aortic valve with a slightly oversized valve that we took. and a pre-dilatation balloon also we decided it as 22 millimeters. The aorta was LV aorta angle was 53 degree, which is a horizontal aorta, and so we would prepare that bicuspid valve with aortopathy and little horizontality would face us challenge, and that's why we did not choose a cell expanding valve, and we went with a balloon expanding valve. There was some LVOT calcium, which was in continuity with the aortic annulus. That was also a small concern in our mind. The iliac femoral access vessels were fine. There was no concern here. And this is these are the pictures of TAVR that we did for her. So planner view alignment was done. And then the coronary protection was done using XP guiding catheter, Guidezilla, and an all-star wire and parking a stent in the left main. And then the valve was crossed with AL1 and the pre-TAVR hemodynamics, which shows a significant LV aorta gradient of 92 and an LV EDP of 35 millimeters mercury. The pre-dilatation was done after parking the confida wire, and the balloon chosen was 22 millimeters, and the pre-dilatation was done to the, the image will come. So that was the confida wire, and this is the 22 into 40 millimeter balloon, which shows the waist, how it opened. And the balloon appears to be slightly big. This was a retrospect analysis that I did. Then the valve was navigated easily. This balloon expanding valve was navigated in the horizontal aorta and positioned. And at 80-20, the positioning was done and deployment was done with RV pacing at 180 beats per minute. So the valve was deployed successfully, and the final result was this. As the balloon was deployed, there was suddenly a little breathlessness that the patient felt, and the echocardiographer, colleague of ours, he did the echo and found that there is possibly a small left to right shunt. So that raised an alarm in our mind that there's some annular or some injury happened to the ventricular septum, and we saw that the coronary left main ostia was flowing good, and we took out the coronary protection system that we had put in place after photogram showing that the left main is flowing well, and the valve was deployed. So the coronary protection system was removed. You can see this picture, and then the shunt was assessed doing an aortogram. You can see there is a small shunt from left to right, and the ventriculogram was also confirmed that yes, there is a shunt. But the echo is, and the patient was stable. There was no desaturation. The hemodynamics were stable, and this was the echo finding. You can see the membranous septum having a left to right shunt. And this is the final shoot, the VSR showing left to right shunt. And the post-TAVR hemodynamics revealed fall in the EDP from 35 to almost 10 or 15, and there was no LV aorta gradient. The patient was shifted to the recovery, and 2 hours later, she complains of some typical chest pain and breathlessness. There was some ST depression, but she had a hypertrophied ventricle, and the coronaries, we saw that they were flowing well. She became tachypneic. She was in heart failure, and the urine output started decreasing overnight. By morning, although overnight she was having a stable hemodynamics, rather blood pressure going high from some sympathetic overdrive also, she had to be mechanically ventilated because the lactates were around 12 to 14 by 9 a.m. next morning. And then the subsequent course in the hospital was acute kidney shutdown, cardiogenic shock, intra-aortic balloon pump. And when she did not stabilize with intra-aortic balloon pump, in the recovery we had to put ECMO. And on echo examination of each successive day, we saw that the RV was dilated and dysfunctional, and it never picked up. She subsequently got complicated with raised liver enzymes to 10,000 and multi-organ failure. Her kidney never opened till the end, and she had sepsis, DIC, and finally she succumbed. So what went wrong? Was she a moderate CKD and some extra contrast, and there was no hypotension? So this acute kidney injury happening so quickly and intractable lactic acidosis was unexplainable. By morning, she went into cardiogenic shock. Her left ventricle function was never impaired, but the RV remained dilated. The shunt was not hemodynamically significant as assessed by us over each day, but at one point of time we felt possibly the shunt increased and it caused a RV overload, volume overload, and the RV, it prevented the RV from improving. And so probably this was the cause of her cardiogenic shock, which never improved, and then it got complicated with the with the adverse effects that ECMO can have if used, if prolonged. We had
kindly
9 to 10 days of
show concluding slides. We have short of time. We'll have to.
So the message here is a balloon expanding valve in the presence of LVOT calcium is not a great choice. Self-expanding valve could have possibly avoided the injury to the septum, and choice of pre-dilating balloon was also a bit large. It was a 22 millimeter valve and the minor axis was 22. 20. So possibly an oversized balloon dilatation and a little oversized balloon expanding valve in the setting of a LVOT calcium and annular calcium probably led to the VSR, and the RV, which was dysfunctional, could not improve as possibly the shunt was large or it worsened over the next subsequent days. So I would say that such minor things can also be sometimes not kept in mind by the most expert hands. We do pre-dilatation for every bicuspid aortic valve, and we do a good pre-dilatation, but calcium spur could be there, which can just poke the membranous septum and cause VSR. So VSR is a very rare complication that can happen, and that could lead to all this catastrophe. So I would like.
So very good, Vijay. And I think because of paucity of time, we may have discussion in the end if we have time. Let me then follow the routine and let me present a case before Dr. Trehan, because we need to finish in time. I'll make it short and quick so that we catch up on the time.